Honorable Chair, respected teachers and distinguished audience, me Dr. Mohammad Abdus Sattar Bhuiyan presenting a case summary. Mr. X, 40 years old male, was admitted into the Department of Cardiology, Mymensingh Medical College Hospital on 5th January 2022 with the complaints of vertigo and headache for 1 day. Vertigo was not associated with vomiting or chest pain or hearing impairment or any kind of visual disturbance or any posture change. Patient has not history of daytime somnolence, and he is hypertensive for last 12 years and diabetic for last 3 years. Clinical findings and anthropometric findings revealed BMI 30.4, waist circumference 96.4, heart rate 92 beats per minute, blood pressure 180 by 120 millimeter of mercury on admission, and 130 by 80 millimeter of mercury on discharge. First and second heart sound was normal, and there is no added sound. Lung bases were clear. Fundoscopy examination revealed grade 2 hypertensive retinopathy, and other systemic examination reveals nothing abnormality. His investigation reveals hemoglobin, complete blood count, RBS, creatinine, electrolytes, and urine RU was normal, and DTP arena scan was done, which was normal. And serum tropi, lipid profile, thyroid profile was normal, except HDL was low, and echo findings reveals concentric LVH and grade 1 diastolic dysfunction, and color Doppler study of the renal artery and high resolution ultrasound of the suprarenal glands revealed normal. Ultrasound from the whole abdomen reveals normal except grade 1 fatty change in the liver and tiny polyp in the gallbladder. And this is the picture of grade 2 hypertensive retinopathy. ECG reveals normal findings, chest X-ray reveals normal, and echo findings reveals concentric LVH and grade 1 diastolic dysfunction. And patient got treatment before admission. ARB tell me certain 80 milligram daily, and calcium channel blocker amlodipine 5 milligram BD, that is 10 milligram daily, and thiazide like diuretics indapamide 1.5 milligram daily. And treatment during hospital admission, to achieve the target blood pressure, the following combination of the antihypertensive medications were used: ARB tell me certain 80 milligram daily, and calcium channel blocker nifedipine 40 milligram daily, and thiazide light diuretics indapamide 1.5 milligram daily, alpha blocker prazosin ER 15 milligram, that is 5 milligram 3 times daily, and beta blocker nebivolol 10 milligram daily, and MR antagonist spironolactone 100 milligram daily. So definition of the resistant hypertension. Resistant hypertension is defined as hypertension that remains uncontrolled with 3 antihypertensive medications, including one diuretic, or blood pressure that is uncontrolled on 4 medications. An epidemiology of resistant hypertension. The estimated prevalence of resistant hypertension among treated hypertensive patients is approximately 13%. And resistant hypertension is associated with older age, black race, chronic kidney disease, obesity, and diabetic. And refractory hypertension. Hypertension is called refractory when it remains uncontrolled, or 5 or more antihypertensive of different classes, including diuretics and MR antagonist. And what are the approach to resistant hypertension? Exclusion of the pseudo resistance, identification and the reversal of the contributing lifestyle factors, withdrawal of the interfering substances or interfering medications, and screening for the secondary causes, and pharmacological and interventional treatments, and referral to the hypertension specialist. And what is pseudo resistance? Incorrect blood pressure measuring technique, poor adherence or compliance of the drugs, white coat effects. And factors leading to poor adherence are the cost of treatments, complexity of treatment, side effects, instruction not understood by the patient, and lack of consistent and continuous primary care. What about white coat effect? Office blood pressure is elevated, already mentioned my previous speaker, my teacher. Office blood pressure is elevated about goal in the office and significantly higher than at home. And diagnosis based on home blood pressure monitoring and ABPM. Identification and reversal of the contributing lifestyle factors are the obesity, physical inactivity, excessive alcohol consumption, high salt intake, and low fiber diet. And screening for the underlying causes should be guided by the clinical clues. And screen for the secondary cause of hypertension guided by the history, physical examination, laboratory findings, and risk factor. And common causes of the secondary hypertension are the chronic kidney disease, renal vascular hypertension, obstetric sleep apnea, primary hyperaldosteronism, and some other causes. And common treatment errors are inadequate doses, inappropriate antihypertensive drug combinations, and use of short-acting drugs, and lack of use of diuretics. And device-based treatment of the resistant hypertension are renal sympathetic denervation, baroreceptor stimulations, or carotid baroreceptor stimulation. This is the percutaneous catheter-based denervation. Renal sympathetic denervation is the catheter-based radiofrequency ablation. And carotid baroreceptor stimulation is also done by newly introduced device. So we have some conclusion or take-home message. Uncontrolled hypertension does not mean resistant hypertension. And exclusion of the pseudo-resistance, implementation of the lifestyle interventions, and withdrawal of the interfering substances are initial steps in approaching the resistant hypertension. And searching for the secondary cause of resistant hypertension should be reserved for the patient with the appropriate clinical clues. And referral to hypertension specialist can help to improve blood pressure control. Thank you, sir.